White crosses in the last best place. They are numerous enough to notice, yet placed infrequently enough to startle those seeing them. They stimulate reverence, sorrow, sympathy, curiosity, and caution. They affect us all to one degree or another. They are the white crosses that mark the sites of fatal traffic crashes along the highways of Montana. For 50 years, these white crosses have reminded passing motorists of the dangers of the road, as well as the lives which have been lost on the highways. The Montana American Legion White Cross Highway Fatality Marker Program began in 1953. The safety program started out as a county and later a district project for the Missoula American Legion Post. However, the idea was so well received that it was soon adopted as a statewide program. The program is intended as a highway safety program. The white crosses serve as a public service message, reminding drivers to please drive carefully. They are a sobering reminder of a fatal traffic crash in a place where a human being lost their life. White crosses make us think of trauma, which is important. Trauma is the third leading cause of death over all age groups and is the leading cause of death for Americans under age 46. Motor vehicle crashes and ground level falls remain the leading causes of traumatic death in Montana. Trauma amounts for more potential years of life lost before age 75 than any other cause, including cancer or heart disease. Trauma is also a disease. Like cancer and heart disease, trauma has identifiable causes, established methods of treatment, and defined methods of prevention. Often in the past, trauma has been referred to as an accident, so many have thought there was really nothing you could do about it. But that thinking is very far from the truth. The term accident implies that there is nothing you can do to prevent it, when in fact, most trauma is very preventable. Studies reveal 90% of trauma deaths are preventable. In fact, injury is America's most expensive disease process, accounting for over $670 billion in medical costs each year. According to the Centers for Disease Control, reduction of trauma provides the greatest potential for health improvement. Let's talk now about what a trauma system is. A trauma system is an organized, coordinated effort in a defined geographical area that delivers the full range of care to all injured patients and is integrated with the local health system. The true value of a trauma system is derived from the seamless transition between each phase of care, integrating existing resources to achieve improved patient outcomes. Implementing an effective trauma system can result in a reduction in preventable deaths. There are nearly 150,000 trauma deaths annually. 20% of these could be prevented with optimal trauma care in a system. Trauma is a very time-sensitive disease for which the term the golden hour was coined, referring to how quickly life-threatening injuries must be identified and treated in order to save the victim's life. The goal is to designate all hospitals and those rural health clinics that receive injured patients from local ambulances as trauma facilities. Designation level is based on the resources available at the facility. An inclusive trauma care system provides for regionalization of trauma care, so all areas of Montana receive the best possible initial and definitive trauma care as we connect the dots up the chain of available care. It is this level of preparation and organization that has been proven nationally to reduce the number of preventable deaths and disabilities. Montana Trauma System's mission is to build and maintain an inclusive, comprehensive system that addresses the daily demands of traumatic injury in Montana. Montana hospitals must be able to provide optimal care for the injured and to function within a regionalized system of care to facilitate rapid transfer to definitive care when appropriate. Rural trauma care in Montana is complicated by geographic isolation, time between injury and discovery, extrication issues, distance to immediate health care, and local health care resource availability. Due to the vast distances between healthcare facilities in Montana, all pre-hospital providers and even some rural clinics must be prepared to provide initial care to injured patients while simultaneously expediting their transfer to definitive care. The Montana Trauma System's lead agency is the EMS and Trauma Systems section of the Montana Department of Public Health and Human Services. This agency is responsible for the oversight of the emergency care system, components of which include the trauma system, EMS system, injury prevention, and EMS for Children programs. They have the authority, responsibility, and resources to lead the planning, development, operations, and evaluation of the trauma system through the continuum of care. This agency, empowered through legislation, ensures system integrity and provides for program integration with other healthcare and community-based entities, including public health, EMS, disaster preparedness, emergency management, law enforcement, fire, and other community-based organizations. The lead agency works through a variety of groups to accomplish the goals of trauma system planning, implementation, and evaluation. The ability to bring multidisciplinary, multi-agency advisory groups together to accomplish trauma system goals is essential in developing and maintaining the trauma system and is part of providing leadership to evolving and mature systems. The initial Montana Trauma System Plan was published in 1994 and authorizing legislation was passed in 1995. Both called for the formation of a State Trauma Care Committee, or STAC, and 3 specified trauma regions based upon patient referral patterns. Montana's STAC consists of 15 members representing a diverse set of stakeholders. A member from each stakeholder organization is qualified to nominate a candidate for each STAC seat. Nominees are submitted to the governor for consideration and appointment to serve a 4-year term. The Emergency Medical Services and Trauma Systems section provides leadership with input from these regional and state trauma care advisory committees. This legislation allowed adoption of administrative rules regarding trauma center designation, classification, data collection, triage criteria, and quality assurance improvement activities. It allowed for trauma data confidentiality and legal protection of performance improvement surrounding trauma care. The following stakeholder organizations nominate qualified committee candidates. The Trauma Regional Advisory Committees are referred to as the RTACs. These geographic regions are based on patient referral patterns. A representative of each facility's trauma committee serves on the RTAC for the region in which the facility is located. RTACs were mandated with the following duties charged by 1995 statutes. Establish standards, policies, procedures, and protocols for the regional trauma care system. Conduct regional trauma care quality improvement, including receipt of reports prepared by the department containing trauma care data and making recommendations to trauma care facilities within the region based upon those reports. Advise the Trauma Care Committee concerning the statewide trauma care system. Establish trauma education and injury prevention programs. Provide advice concerning trauma care to healthcare facilities and other providers of healthcare. Perform other duties required by department rule, and conduct other activities needed to ensure optimal delivery of trauma care services within the region. RTACs provide a forum to ensure a regional approach to the delivery of trauma care with continuous system evaluation based upon quality and performance improvement in trauma registry data. The RTACs assist in developing local solutions to improve trauma care and consistency. Regional trauma center physicians and trauma coordinators provide leadership for the RTAC activities. The RTACs meet quarterly and have been instrumental in providing creative solutions to regional trauma needs. These are the operational components of a trauma system. Optimal care for the trauma patient involves a team approach by healthcare professionals working together to provide for a coordinated continuum of care. We will next review the major components briefly. We will begin with injury prevention. We cannot overemphasize the importance of injury prevention. Most traumatic injury is preventable. Injuries are the leading cause of death for Montanans age 1 to 46. Nearly half of all unintentional injury mortality and morbidity in Montana are due to motor vehicle crashes. Lack of seatbelt use and impaired driving are leading contributors to the high number of motor vehicle-related injuries and death. Falls are the leading cause of injury death among those ages 65 and older in Montana. Half of all deaths due to falls occur in the home. Nearly 900 people are hospitalized each year due to a traumatic brain injury in Montana. Motor vehicle crashes, falls, and suicide are the leading causes of traumatic brain injuries. Unintentional poisoning has emerged as a major health issue, making it the 3rd leading cause of unintentional injury in Montana. The most common cause of unintentional poisoning is overdose of prescription medications, namely narcotics and hallucinogens. Trauma systems must develop prevention strategies that help control injury as part of an integrated, coordinated, and inclusive trauma system. The lead agency and providers throughout the system should be working with business organizations, community groups, and the public to enact prevention programs and prevention strategies that are based on epidemiologic data gleaned from the system. Efforts at prevention must be targeted for the intended audience. Collaboration with public service agencies is essential to successful prevention program implementation. Such partnerships can serve to synergize and increase the efficiency of individual efforts. Alliances with multiple agencies within the system, hospitals, and community associations working together is beneficial. The care of the trauma patient in a trauma system begins at the scene of the incident, and this care is provided by the pre-hospital emergency medical care providers. EMS is often the critical link between the injury-producing event and definitive care at a trauma center. It is a complex system that not only transports patients, but also includes public access, communications, personnel, triage, the provision of care prior to arrival at the hospital, data collection, and quality improvement activities. EMS agencies should have a critical role in ensuring that communication systems are available and have sufficient redundancy so that the trauma system stakeholders will be able to assess and act to limit death and disability at the single patient level and at the general population level in the case of multiple or mass casualty incidents. In most areas in Montana, this care is delivered by dedicated individuals who volunteer to provide this emergency care. EMS is the only component of the emergency health care and trauma system that depends on a large cadre of volunteers. In order to maintain and improve this invaluable component of the trauma system, we must keep this workforce and provide them with current trauma care education. In some smaller facilities, EMS personnel also become part of the emergency resuscitation team, augmenting hospital personnel. The Trauma Care System program should reach out to these volunteer agencies to help them achieve their vital role in the optimal outcome of care for trauma patients. Now we'll move to acute care facilities. This component of the trauma system refers to all the medical facilities that provide primary emergency patient care. The trauma system ensures a systematic way of providing emergent, life-saving care through an organized team approach. This picture shows the Billings Clinic trauma team. The emergency department is the first department of the acute care facility where the trauma patient is usually cared for, but this is not the only part of the facility that is the trauma center. Included are all departments and services involved in the care of the injured patient, such as lab, diagnostic imaging, surgery, ICU, rehabilitation, and others. Designation as a trauma facility in the state of Montana is a process for the acute care facilities. The process of trauma center designation is voluntary. Minimum acceptable standards, modified from the ACS, for facilities in the state seeking trauma center status exist. Montana recognizes the importance and special needs of its smaller medical facilities. The Montana Trauma Facility Designation Criteria is the criterion which details the essential and desired human and material resources required to tend to the emergent needs of the injured patient at each designation level. To avoid the concept that one level is necessarily better than another, numeric indicators for facility designation have been avoided. Rather, a descriptive title of the trauma care capabilities of the facility is used. 4 levels of trauma designation exist: regional trauma centers, area trauma hospitals, community trauma facilities, and trauma receiving facilities. Let's move to the rehabilitation section of the circle. Rehabilitation services are an integral component of the trauma system to provide coordinated care for trauma patients who have sustained severe or catastrophic injuries. Fully developed trauma center programs and trauma systems should include resources and processes to support rehabilitation of the trauma patient. The goal of rehabilitative intervention is to allow the patient to return to the highest level of function, reducing disability, and avoiding handicap whenever possible. The rehabilitation of injured patients should begin the first hospital day. Acute care should be consistent with the preservation of optimal functional recovery. The ultimate goal of trauma care is to restore the patient to pre-injury status. Not only is this effort best for the patient, it is also less costly. When rehabilitation results in independent patient function, there is a 90% cost saving compared with costs for custodial care and repeated hospitalizations. Trauma is the leading cause of disability in the world. In-hospital trauma-related mortality has decreased to just 4% in the U.S., but little is known about the 96% of patients who survive their trauma injuries and suffer debilitating long-term effects. An important function of the trauma system lies in emergency preparedness. Montana's Public Health Emergency Preparedness Healthcare Preparedness Program coordinates the state's response to public health threats of all types, including natural disasters like hurricanes and floods, and man-made emergencies like industrial spills and explosions. The Emergency Medical Services Trauma System works in partnership with HPP to provide the state with an effective response through the integration of EMS and trauma system components with emergency preparedness planning. A mass casualty incident, often shortened to MCI, and sometimes called a multiple casualty incident or multiple casualty situation, is any incident in which emergency medical services resources, such as personnel and equipment, are overwhelmed by the number and severity of casualties. Depending on the geographic area and available hospitals, even small numbers of patients can tax the local emergency system. To streamline processes for ensuring appropriate routing of patients involved, Montana Trauma System endorses the use of the START triage guidelines to identify patients. Planning for and responding to emergencies depends on numerous factors, including geography, type of healthcare delivery system, threats and hazards, and demographics. Through the development of healthcare coalitions that link all players in the healthcare system to emergency preparedness activities, HPP provides technical assistance and facilitates coordination between the healthcare system, public health agencies, emergency management organizations, and others. HPP addresses gaps in healthcare preparedness through capacity building activities, identifying hospital bed surge capacity, and training in diseases caused by bioterrorism. Regional grants support involvement in jurisdictional and regional planning, training, and exercising, resulting in stronger, more resilient systems that can adapt to new threats. Many other time-sensitive emergency systems are molded using the trauma system principles, such as evidence-based care that addresses public education and prevention, 911 access, response coordination, pre-hospital response, transport, and quality improvement. These other systems include STEMI cardiac arrest and stroke. The organized team approach currently used for the care of the injured can be expanded to include the various responses required during many emergency care situations. Many time-sensitive patients can benefit from the trauma system organization of patient identification, triage, resources, staff, capabilities, and transfer processes already utilized for trauma patients. Adaptation and extension of the existing mechanisms rather than creating parallel systems, offers further system efficiencies and improved utilization of limited resources for patient benefit. This is a picture of the ambulance entrance for the Wheatland Memorial Hospital in Harleton. The trauma reviewers particularly like this sign, "Don't even think of parking here." The people in this picture are Lori Pritchard, the Director of Nurses, and one of the trauma surgeon reviewers, Dr. Stuart Reynolds. Dr. Reynolds, who was a general surgeon in Havre, was instrumental in the development of the Montana trauma system and helped many other states such as Oregon, Wyoming, Washington, and Colorado. Learning from each other in trauma is a key element of our success. The committed willingness of everyone to share information with each other for the purpose of improving trauma care is very exciting. We do not believe in reinventing the wheel, but instead help each other toward that common goal.